Okay, shall we start now?
Yes, yes, sure.
Okay. Good morning, everyone, respected faculty and dear delegates. On behalf of the organizing committee, I, Dr. Askia Sultan, welcome you all to the 17th National Conference of Hospital Infection Society, India. Healthy women and children are the foundation of healthy society. Keeping this in we have our first Meet the Expert session on preventing infections and in neonatal and obstetric units. I would like to begin this academic feast with the talk of Dr. Zahra Mohsin. She is professor in Department of Obs and Gynae, Jawaharlal Nehru Medical College, AMU Aligarh, and a great teacher. She has a special interest in gynecological oncology and high-risk obstetric surgery. She will be talking about antimicrobial stewardship program in obstetric facilities. Over to you, ma'am.
Thank you so much for your kind words, Asfia, and thank you also for making me a part of this program. Now, you please give me the sharing rights, Asfia.
It's given, ma'am. Please share.
It's given, ma'am. You can click on the share button on the toolbar.
Can you see the screen now?
Yes, ma'am. Yes.
So, thank you so much for making me a part.
Ma'am, please start the slide share.
Shall I start the slide share? I'm already sharing. It says you are sharing your screen.
Name on the PowerPoint.
Put it on slideshow mode.
New share?
Slideshow mode. Then below.
All right.
Yeah, please continue.
Thank you for making me a part of this program, and good morning to everybody. We all know that antimicrobial resistance is now the health threat that we face today. And the answer to this threat is an antibiotic stewardship program. Now, these antibiotic stewardship programs have certain core elements, as you can see. The main and the most important core element is enhancing infection prevention and control and controlling the source of infection. As obstetricians, the most common procedure that we do is a cesarean section. And this is the major cause of infectious morbidity, post-operative infectious morbidity in our department. Hence, a pre-incision antibiotic prophylaxis, single dose is recommended, and it reduces the risk of endometritis by almost 46% and wound infection by 41%. WHO and the American College of Obstetricians and Gynecologists recommends a single dose of first-generation cephalosporin for prophylaxis. This dose has to be repeated if the procedure is more than 4 hours long or the blood loss is greater than 1500 ml. Now, in our country, we believe that a single dose is not enough. Most of us use multiple doses and also follow it up with a course of oral antibiotics. Now, we have accumulated data. Even a study was done in our hospital because most Indians believe that our women are more nutritionally deprived and hence more immunocompromised and therefore need more antibiotics. But that is not so. We have seen that a single dose antibiotic is as effective as using multiple doses. The incidence of fever, as you can see, wound infections are almost similar. There is no significant difference. The incidence of UTI and endometritis is also comparable. there is no significant difference in post-operative infectious morbidity. This was also proven by a meta-analysis done in 2017, and that also showed a non-significant difference between a single and a multi-dose antibiotic prophylaxis to prevent infectious morbidity. The other belief among us is the broader the spectrum, the better. So even if we are using a single dose antibiotic, we feel it should be a broad spectrum antibiotic because most of these infections are hospital acquired, and therefore the spectrum needs to be broader, the antibiotic more effective. But again, it has been proved that a first generation cephalosporin like cefazolin is as good as a third generation ceftriaxone in preventing overall infectious morbidity. The difference in wound infection rates, UTI, febrile morbidity is quite similar, as you can see in the table. The importance is that one should remember Ignaz Semmelweis, who changed modern medicine when he showed that a simple little step like hand hygiene was crucial in preventing infections in an Austrian obstetric clinic and reduced mortality from 10 to 2%. So we have to emphasize on the little things, yet very significant, like bathing a day before or on the day of surgery, clipping hair instead of shaving before the operative procedure, avoiding an indwelling catheter in an uncomplicated cesarean where injuries to the bladder are not expected. We have again in our hospital seen that in patients who were not catheterized in uncomplicated cesarean sections, the incidence of UTI was only 2% versus 16% in patients who were catheterized. So if one can, one should avoid catheterization in uncomplicated cesarean sections. Then skin preparation using a 2% chlorhexidine alcohol solution is recommended for reducing infectious morbidity. Vaginal preparation using povidone, preferably povidone iodine 5%, reduces post-operative infectious morbidity. Then regarding the technique, it has been seen that during cesarean, spontaneous delivery of the placenta versus manual delivery reduces the risk of endometritis. Non-closure of the peritoneum causes reduced febrile morbidity. Subcutaneous tissue closure should be done if it is greater than 2 centimeters thick. Subcuticular stitches are better than staples. Infectious morbidity and wound dehiscence is much less with subcuticular stitches, and a routine use of drain is not beneficial. We feel drains will drain the wound and reduce infectious morbidity. That is not so. Then post-operative care, NICE in 2018 recommends that the dressing should be removed the next day and the patient should be asked to bathe daily thereafter. So it is these small things that matter. We must remember that 50% of the antibiotics that we use are inappropriate. And we have to choose the right patient at the right time, giving the right drug, the right route, the right dose for the right duration. In obstetrics, a lot of procedures like uncomplicated deliveries with an episiotomy, instrumental deliveries do not need any antibiotic prophylaxis. Hence, it should not be given. So we have to prescribe only when it is necessary. We have to make an effort to send a culture where possible. Most of us initiate treatment without sending proper cultures. So the antibiotics that have to be given should be started after a culture. Please follow guidelines. There are Indian guidelines, the ICMR, the other Indian guidelines, which are based on the antimicrobial resistance data available in the country. But none of us are aware of these guidelines. So we have to make sure that people are aware. Use the shortest duration based on evidence. Then in a facility, we should have some knowledge of our local antimicrobial resistance. Antibiograms are of great help in offering empiric rational treatment. One other important thing is that we must, in the department or in the facility, have a list of restricted antibiotics. These antibiotics can only be used after approval from a senior consultant or a senior or a microbiologist. So that is very, very important, and it has to be emphasized. Then these are the core elements. Continuing with the core elements, the most important aspect of any stewardship program is to educate. So create awareness in your staff, in the clinicians, nursing staff, even MTS and cleaning staff. All need education, awareness, and training. The residents and the clinicians should be encouraged to adopt national guidelines, and we have to look at our local data. We have to analyze this data and manage as per the resistance patterns. We can also create our own regulations and guidelines depending upon the data. And the most important thing, last but not the least, is to create a multidisciplinary team. The work of this team is to create awareness, to analyze the data, and to have an action plan. So thank you so much. An antibiotic stewardship program is essential for a good clinical outcome, and we need to have a program in almost all facilities. Thank you so much for your patient hearing.
Thank you, ma'am, for illustrating the importance of antimicrobial stewardship, which is a mandate these days.
Yes.
Proper sterilization and cleaning is one of the pillars of an effective infection prevention and control program in any hospital setting. To discuss this pertinent topic, we have amongst us Dr. Sujata Babecha, Professor and Head of Department of Microbiology at Lokmanya Tilak Hospital, Lokmanya Tilak Municipal General Hospital and Government College, Sion, Mumbai. She is also the Vice President of Hospital Infection Society India, and she will be discussing about the disinfection of surfaces and equipment in neonatology and labor rooms. Over to you, ma'am.
A very good morning to all of
Sorry, that mistake. President, please play that again.
very famous neonatologist from India, Professor Baku said, if you want to prevent the neonatal sepsis, you have to follow the microbe in the journey from hospital environment to the bloodstream and examine the practices. So for this, what we have to do? Basically, we have to prevent the entry of microbes into an ICU, preventing the proliferation of microbes into the ICU, prevent the baby-to-baby spread of the infection, decrease the entry of microbes into the baby, and need to have better administrative practices. Normally, in 40 to 50% of the cases, it is the endogenous flora which plays an important role as a source of healthcare-associated infection. Only 20 to 40% cases, it is the hands of healthcare workers or the visitors. In another 20%, it is the medical devices because of direct and indirect contact with the environmental surfaces, which play a role as a source for healthcare-associated infections. Neonates are always at risk. To begin with, when they're passing through the mother's womb during delivery, there's so much spillage of blood, body fluids, So many things are happening. They are at a great risk. Then the low birth weight, decreased gestational age, decreased immunity, inadequate skin barrier, all these factors predispose them at a high risk for acquiring infection. To top it up, we have so many devices put on the neonates. We have poor nursing ratio. These neonates are on prolonged antimicrobial therapy. There's a prolonged length of stay. So they are at an increased risk. Now the question is why we are talking about decontamination of surfaces. Do they actually play a role? You will get your answer. Normally, the surfaces get contaminated with epidemiological important pathogens like MRSA, VRE, Clostridium difficile, and even SARS-CoV-2. And these are the surfaces which are touched by healthcare workers. Healthcare workers now transmit, because of the contaminated hands, to these neonates. The good thing or the bad thing is that these epidemiological important pathogens survive on surfaces, not for few hours, but many times for many months. And it has been seen that reducing the burden on the surfaces can definitely reduce the risk of transmission and burden of healthcare associated infections. So what is to be done? We need to have ideally a bundle approach. What is this bundle approach? It means you need to have a policy and practices in place. You need to select an appropriate cleaning and disinfecting agent. You need to educate people, and also you need to monitor the compliance and try to implement no-touch decontamination technology. The first things, that is policy and practices. What needs to be done? What are the policies we have? How often you should do the cleaning? When to do the cleaning? Comes all under policies. Yes, you have to regularly clean it. But how often you're going to clean it depends upon the frequency, depends upon either you're in a critical area, non-critical, high touch, or infrequently touched surfaces. This can vary from daily to weekly. So you need to do regular cleaning. But in certain situations, after the patient is discharged, you may have enhanced cleaning practices. And if the patient is admitted with a highly infectious thing, or he gets discharged, or there's a loss to life, you need to have terminal cleaning also. The other thing is, who's going to do it? Yes, it has to be trained and competent housekeeping staff who is going to do it. So you have decided how often you're going to do it. How do you decide a product? The selection of a product also depends on the setting. Normally, a detergent and a simple disinfectant is sufficient for most settings, including labor ward and NICU. One should avoid phenolics in NICU settings. But what is important is you have to use an approved disinfectant at the right concentration. Because there are some organisms like Clostridium difficile or Candida auris, which may require higher concentration. Like simple example, like normally for a surface disinfection, 0.5% sodium hypochlorite is sufficient. But if it is a case of Clostridium difficile or Candida auris, we need a higher concentration to 1%. And another thing important about the disinfectant is it needs to remain wet for at least 1 minute. It should not evaporate immediately. Otherwise, it won't be able to act. And there are some disinfectants which require dilution, but please do it properly. That also thing has to be kept in mind. When we are carrying out these disinfecting practices, you have to wear appropriate personal protective equipment. Nowadays, even many wipes which are available, they're coming to the market. They're very easy to use and they're very good for horizontal surfaces. So one can even try that. This is a standard chart or slide by the CDC. what you can see here is prions are the most resistant, and lipid or medium-sized viruses like HIV are the most susceptible. So simple disinfectant measures like 0.1% sodium hypochlorite is sufficient for them. But as you go higher up, like for mycobacteria or coccidia-like thing, you will require a high-level disinfection, or for bacterial spore, you will definitely require sterilization. Now we know that we have to choose an appropriate disinfectant and we have to carry this appropriately, but human behavior behaves differently. Till things are monitored, the compliance tends to fall. Otherwise, we will never have any outbreak. So one has to monitor this compliance, especially if not every day, especially when the procedure is first established. When there is an outbreak, when you're changing a protocol, there are different ways by which you can check nowadays. One is, yes, you can visually do that, but the systems like ATP bioluminescence also, which is there, though they're a little expensive. A simple culture in which less than 2.5 colony forming unit per square meter tells you that you've done a good cleaning and disinfection. These things are now available for monitoring the compliance. There's some no-touch techniques which have come up for decontamination. That is, after the patient is discharged from the room, you can use UV light or you can use automated system of disinfection the whole room. These are available and preferred after, and these are to be used when there is nobody in the room. Now, other things which are there in NICU is your equipment. The broad principles are, you need to have your list and identify the equipments both in the labor ward as well as in neonatology. And you need to classify them as critical, semi-critical, non-critical. So depending upon that, you're going to use your method. If it is non-critical thing, patient care equipment, you can use simple things like sodium hypochlorite, 70% alcohol or quaternary ammonium compound. For semi-critical things, you need to have, of course, an appropriate, approved registered disinfectant, which has to be used at a proper concentration and for a proper contact time. But in addition, because the contact time may be more, you need to check that there is a material compatibility. If you use sodium hypochlorite on many things, they will get spoiled. So that's very important. So in these scenarios, what you should do is choose a disinfectant with a short turnaround time and good effectivity, like vaporized hydrogen peroxide, exudated hydrogen peroxide, peracetic acid. These are good. And for critical situation, disinfection is really not recommended. That's very important. These are simple things, simple examples in NICU, like baby linen and blanket cover. They have to be, of course, washed and autoclaved every time, each time before use. Feeding utensils have to be washed. Everything. Please remember, cleaning is something which removes organic matter and removes even microorganisms. Disinfection is something which kills the microorganism, not fully, though. So like feeding utensils, you have to wash with soap and water. So you have to clean everything first. And then you can boil for 10 minutes. The other things which have to be used on patient, as far as possible, use things which are autoclavable. So like, chittle forceps, you should never put it in a liquid. You have to autoclave this, put it in a sterile autoclave bottle with a dry sterile cotton. That's really important. Things like stethoscope, measuring tape, they all can be cleaned with simple spirit. Embouche bags and, laryngeal blade. Many people are using high-level disinfectant like glutaraldehyde, but in our setup, we don't do it. We wash clean and send it for ETO sterilization. We do not believe in any kind of high-level disinfection. The reasons are very many. We are a tertiary care hospital and are really overcrowded. So we don't want to take any chance as far as this is concerned. This principle again remains the same. You see, the warmer is something which we have to clean it very well. You have to use, of course, a sterile cloth which has a soap water, then dry it out and again wipe it with a simple disinfecting like 0.5% bacillus or 1% work on. And you have to do this every time the patient is discharged or you shifted the baby. So these things are, done that way. Please remember, if the equipment is visibly dirty, use soap and water. You must use and remove all visible contamination. Then wipe with a sterile moist cloth using disinfectant, which could be bacillus or anything which is available in your setup. Do not use Vercon or sodium hypochlorite on the medical devices because they're not compatible, and then they tend to, they tend to be, become corrosive. This principle again is the same, like you have to clean your laminar flow every time you're doing it. If it's visibly dirty, use soap and water and do it. Otherwise, and whatever you can sterile, make it sterile, please do that. That's really very important. So to summarize, there is an evidence which indicates that there is a role for contaminated environment in the disease transmission. All touchable room surfaces, it's not only the high touch, everything gets contaminated. And when you improve your surface cleaning and disinfection, it reduces the healthcare associated infection. It is not the product, but the methodology which determines, that is, effectiveness of the disinfectant. You have to use properly in an appropriate manner as per the manufacturer's recommendations for an appropriate or the recommended time. Implementing bundle approach for the surface disinfection is the need of the day, and all equipment has to be disinfected. Please remember, as per the manufacturer's instructions. Thank you very much. We have a question answer session, I believe. So
Thank you, ma'am, for the concise talk. As we all know, recent pandemic of COVID-19 has exhausted all our resources and shaken our health systems. And definitely it has not spared the pregnant females. I invite Dr. Tamkeen to discuss the COVID-19 guidelines in obstetric and gynecology practice. She is the professor in the Department of Obs and Gynae, JNMCH, AMU Aligarh, and she is the National Mentor of Quality Improvement Lakshya Program and also the Founder Secretary of Stillbirth Society of India. Over to you, ma'am.
Thank you so much, Asfia. Good morning, everybody. And I'll be talking about giving you an overview about the COVID infections for pregnant women. So my talk is based on several international guidelines. The most recent being the Society for Fetal Medicine, Fetal and Maternal Medicine on 1st July 2021, which has been endorsed by ACOG. A few slides from FIGO, but I would advise everybody to keep updating themselves every day because new evidence is emerging and the data keeps on changing every day. For pregnant women, the recommendations are almost the same as non-pregnant, except that pregnant women with children should exercise caution while they are moving out. More than 90% of infected women, they will recover uneventfully, but pregnant and recently pregnant women are at an increased risk for severe illness, both for ICU admission, need for mechanical ventilation and ventilatory support, and death, as well as going into preterm labor. And because of that, their babies are also at more risk of NICU admissions and other complications. We advise all pregnant women and their family members to be vaccinated. Pregnant healthcare workers who are in the third trimester, particularly more than 36 weeks, should stop face-to-face contact with patients. So this is the evidence which has proven that it is, if the infection occurs in a pregnant lady, it is going to be more severe with more morbidity and mortality, both for the mother and the baby. And that is why we need to update ourselves. The clinical features are same as those of non-pregnant: fever, shortness of breath, sore throat, myalgia, etc. COVID-19 in pregnancy is associated with consistent and substantial increases in severe maternal morbidity and mortality and neonatal complications. This is from a multinational cohort study of more than 2,000 pregnant women in 18 countries. So whenever she's pregnant, she's more concerned about her baby. We need to counsel her that the extent of vertical transmission remains unclear as of present. Only few documented cases of probable vertical transmission have been published. All those cases which occurred did not satisfy the strict criteria for a vertical transmission. Many other possible causes of congenital infection have been reported in the third trimester maternal infection within 14 days of delivery. And the risk is approximately only 2%. And again, this is another large trial which has proved this. Is the assessment of severity of COVID different in a pregnant woman? Please, I would like to emphasize again that for the non-pregnant patient with COVID-19, recommendations are to maintain an oxygen saturation of 92% or greater. But for any pregnant woman, the saturation has to be 95% or greater. So this is the difference between the pregnant and the non-pregnant. So please remember that the criteria for mild, moderate, severe, and critical disease is different. The main difference being the respiratory rate and the cutoff value for oxygen saturation. Antenatal care for COVID positive pregnant women, the general principles: you need to isolate, use as much as possible telemedicine, because you are yourself you're putting yourself at risk as well. Do not advise them to attend routine clinics. Suspected cases to report at designated triage for assessment. Keep minimum number of people with her. Use private transport, and if an ambulance is required, inform call handler about the current status of the woman, and advise good diet, hydration, and standard precautions, of course. Decrease the amount of visits and postpone the visits, and increase the interval between visits during COVID times. Shorten the duration of visit and limit the visitors who are accompanying the pregnant woman. So it is recommended that just four visits would suffice for an antenatal visit during COVID times, which are scheduled at 12, 20, 28, and 36 weeks if she is low risk. When you advise care at home, advise on diet. She has to be well hydrated, and blood pressure, maternal weight, and daily fetal movement count. Whenever you are assessing whether you want to treat her at home or you want to hospitalize her, you have to keep three things in mind. Number one, the medical risk assessment for herself, the obstetric risk assessment for herself, and the social risk assessment, how much she's going to cause spread of the infection in the society. Any comorbidities indicate that admission is required: hypertension, diabetes, asthma, HIV, heart disease, liver, kidney, or lung disease, blood dyscrasias, or any patient who has an immunosuppressive disease or is on medication has to be admitted, whether it is mild disease or it is any other type of disease. How do you manage confirmed cases? If they are mild, asymptomatic, patient has tested positive, there are no comorbidities, there are no obstetric emergencies, she's not in labor, and her saturation is maintained above 94, then you just home isolate her, and maybe after 2 weeks, when she has tested negative, you can get a color Doppler done for her, especially if she's in the second half of the pregnancy. While she's at home, she needs to isolate in a well-ventilated room. Do not share personal items with other people, and clean the surfaces which she touches with 1% hypochlorite frequently, and maintain respiratory and hand hygiene. Government of India on 28th April also released tips for home isolation, and I have based this PPT on that. She has to stay in touch with a physician. Symptomatic management of fever is done, running nose, cough, etc. You may advise her warm goggles or steam inhalation, and if fever is not controlled, she's advised paracetamol 650 milligram 4 times a day, or maybe cold sponging, as well as naproxen may be added. She can monitor using this chart, where she's keeping a record of her temperature, daily symptoms every 4 hourly, heart rate, SpO2, whether she's feeling better or not, and her any breathing difficulty. What are the danger signals when she needs to take medical care? Well, whenever there is a worsening dyspnea, oxygen saturation is less than 95% at rest, or exertion, there's an unremitting fever, inability to take things orally, persistent chest pain, confusion, or she has any obstetric complications like she has bleeding or preterm labor. So antenatal contact after recovery from illness, how soon you will call her. If she was in the first trimester, you can delay it till 20 weeks. I already mentioned if she's in the second trimester, call her after 2 weeks. Probably by that time, she would have tested negative, and any effect on the baby will be detected by ultrasound like a oligohydramnios or an IUGR. The people who are her caregivers also need to be taken care of. They should be wearing masks and they should not be in the same room. All those precautions that we advise. Food must be provided to her in her own room. Utensils and dishes used should be cleaned properly with soap and water, wearing gloves, and they can be reused. Admission will be required if there is moderate to severe disease with a saturation less than 95%, pregnant patient with comorbid conditions, and those who have no facility for home isolation, living in a single room, maybe the whole family, something like that, or if there is any obstetric indication. Mild disease, when there is no shortness of breath or abnormal chest imaging. What do? uh, uh, you home isolate. For moderate disease, whenever there is less oxygen saturation, or there is a persistent fever for more than 5 to 7 days, or there is evidence of lower respiratory tract illness like dyspnea, pneumonia, even when there is imaging is normal. So all these will require admission. You need to send investigations, repeat the investigations every 48 to 72 hours according to her condition, and monitor her vitals 4 to 8 hourly, and only symptomatic treatment is given to these women. But if in these cases the fever is persistent for 5 days, then you need to start antibiotics, steroid, and anticoagulation for a short duration. Those with severe disease, when the respiratory rate is more than 30 beats or the saturation is less than 94, then, or there is more than 50% involvement on imaging of the lung, then you call it severe disease, and you have to obtain vital signs every 2 to 4 hours, send relevant investigations, provide her oxygen support, and look out for any need for mechanical support. You give her anticoagulation, steroids, and antibiotics. What are the indications for admission to ICU? Inability to maintain a saturation more than 95%, hypotension, or when you have evidence of end organ failure or multiple organ failure. So, and when multiple organ failure has been documented, then it is critical disease, or when she is in shock, or she's not able to maintain mechanical saturation on mechanical ventilation. So, what is the whole list of investigations that you need to send from moderate to severe to critical? So, mild disease requires no investigations. Moderate disease will require these blood investigations. But I want to emphasize that a chest radiograph may not be routinely required unless there is a fall in saturation. And a single chest radiograph does not harm the pregnant lady or a baby. Do not deny her the facility of computed tomography for her management, but do not overuse it. Okay, so if you can do with a chest x-ray, it is okay, but if it is required, do not deny it if the illness is severe or critical. She needs to be put on steroid. And what is stepping up of steroid therapy? Well, the indications: moderate to severe rise in respiratory rate or fall in saturation. Bronchopneumonia is there. There's a marked rise in pro-inflammatory markers with symptoms. All these will need steroids to prevent a cytokine storm. And also in mild cases, when there's a persistent fever, then you can start her on steroids for 3 to 5 days, whether oral or injectable. Then moderate disease, you need to give her injectable prednisolone. But when remember that prednisolone does not cause, methylprednisolone does not cross the placenta. So the benefit of lung maturity will be denied to the woman in this case. And you may start with prednisolone, but if you need to terminate the pregnancy, you can switch over to dexamethasone, which crosses the placenta. Uh, then coming to when to terminate the pregnancy, no indication of termination of pregnancy except for obstetric indications. I repeat, no indication of termination of pregnancy except for obstetric indications. There's a big dilemma in severe COVID with refractory hypoxia when the woman is beyond 32 weeks, whether to manage her conservatively or whether to conduct a delivery. So the only indication for cesarean section and taking out the baby and termination of pregnancy is persistent inadequate oxygen or ventilation despite substantial and appropriate measures to optimize it and represent a further escalation of severity on the spectrum of disease. Remember, whenever you perform a cesarean section, you increase the chances of morbidity and mortality. Termination of pregnancy in refractory hypoxia, delivery may be considered at more than 32 weeks. It is unclear whether it will provide substantial improvement. Mechanical ventilation alone is not an indication for delivery. That she is on a ventilator, it does not mean you have to take out the baby by a cesarean section. If delivery is considered based on severe hypoxia, other options should be discussed like ECMO and prone position. What is the preferred mode of delivery? Any specific care around delivery, medical or obstetric? Well, the mode of delivery for COVID positive women, vaginal or cesarean, the rate of neonatal COVID-19 infection, neonatal deaths, and maternal deaths are comparable, whether you deliver her vaginally or you perform a cesarean section. So, cesarean section ideally should be undertaken only when indicated by an obstetric indication. And this is from a large systematic review published in February 2021. Vaginal delivery should be instructed to wear during labor. The woman should be instructed to wear a mask. Then birth companion, if allowed, should be tested negative and remain with the woman throughout labor during using COVID appropriate precautions. And epidural anesthesia is good for pain relief because you can quickly convert it into, if you need a cesarean section, you can quickly transfer the patient for the operation theatre. Should the COVID positive woman be offered delivery if she's near term? No, the COVID positive status per se is not an indication for elective delivery, even if she's on oxygen or mechanical ventilation. I repeat, COVID positive status is not an indication for elective delivery. Need for termination of pregnancy is decided based on her maternal condition, fetal viability, and likelihood of maternal improvement after delivery. So only those cases who have worsening or refractory hypoxia, in spite of being on ventilator, then only you may think in terms of termination of pregnancy, and that too not necessarily by cesarean section. Cesarean section may be considered in a woman near term unable to maintain saturation on ventilator. Refractory, which I already mentioned. So planned inductions of labor or cesarean delivery of COVID positive women, if she's around 37 to 38 weeks, it is better to wait because in another 14 weeks, she may become RT-PCR negative and then there'll be rest risk to the healthcare workers. Around 39 weeks, it is better to terminate. Why? Because disease may worsen and the prognosis for the woman and the baby may worsen. So medically indicated delivery should not be delayed solely because she has tested COVID-19 positive. During labor, take high-risk consent, provide routine care in first stage, let her be ambulatory if she can walk around, give her oxygen mask only if it is required and the saturation is less than 95%. You may cut short the second stage if you think it is indicated and there is dipping saturation. You have to do the active management of third stage of labor. There's no risk of increasing the transmission of rate of transmission. You have to be ready for postpartum hemorrhage. Remember, it has to be delayed cord clamping for all COVID positive mothers. It does not increase the risk of vertical transmission. So managing anticoagulation, just stop before surgery if you're planning a cesarean section like 12 hours, and whether you want to continue it after she has undergone the surgery will depend upon how much at risk she is for venous thromboembolism. So like any other non-pregnant, that is decided how long you're going to continue the thromboprophylaxis. What are the postpartum dilemmas? Whether the baby should be separated, whether we should allow her to breastfeed, and is there any other problem related to COVID-19? So all women should be roomed in with babies and babies should be breastfed. Breastfeeding should be encouraged as per Government of India, FIGO. No baby should be denied the benefit of breast milk just because the mother is COVID positive. Only thing is that she has to take certain precautions, and the precautions are that maybe the baby may be kept apart except while she's breastfeeding. She has to wear a mask and she has to wash her hands before. Vaccination, where do we stand today? It is very clear. Almost every guideline had allowed vaccination of pregnant women and breastfeeding women. Only there was some delay in India, and on 10th May 2021, every breastfeeding woman was allowed COVID vaccination. And on 2nd July, after much advocacy by the Federation of Obstetrics and Gynecological Society of India, the government has allowed vaccination for pregnant women as well. A few drugs which may or may not be allowed during pregnancy. So remdesivir is one drug which is not should not be withheld from the woman if she requires, and mostly it is moderate to severe disease but should be given within 10 days of the onset of the symptom. And no known fetal toxicity is there, and the Society for Maternal and Fetal Medicine recommends that it should be offered to all pregnant women who meet the criteria for compassionate use of this drug. Tocilizumab is the monoclonal antibody, may be used in severe disease, but there's not enough data. You have to see the risk-benefit ratio. Avoid ivermectin, doxycycline, and the other monoclonal antibodies. So normalize managing COVID positive patient during pregnancy. Majority will require just home isolation. Be competent in telemedicine and advising her home isolation. Recognize danger signs and train her to recognize danger signs if she's home isolating. Avoid any unnecessary medications during pregnancy. Liaison with a physician and COVID managing facility. Continue respectful maternity care should not be denied, and the presence of a birth companion should not be denied. Continue breastfeeding in postpartum period. Contraception and mental health should not be neglected. All contraceptives are safe for COVID positive women. Vaccine advocacy should be strengthened, especially for pregnant women. Thank you so much.
Thank you, ma'am, for taking such an talk. Now it's time for the last segment of the session on clearing doubts and resolving controversies. For this, we have our experienced teacher, Professor Seema Hakim, with us. She is the coordinator of Medical Education Unit at JNMCH AMU Aligarh, held many administrative positions, and has various awards to her credit. I request Professor Seema Hakim carry forward the discussion with our eminent dignitaries.
Thank you, and a very good morning to everyone. Every speaker have done their best, and it was really a wonderful session, I must say, from basic to, so coming on to, so you really did a wonderful job. You highlighted the stewardship program for antibiotics in obstetrics unit, especially we deal with so much of infection in our patient because all of them, they are coming very late, and they are, most of them, they are high risk. They are being treated outside without following the infection prevention practices. So my first query to you is that you said that you did a lot of work on infection, single antibiotic and multi-dose antibiotic, and we are mostly following single-dose antibiotic. But your figures tells us that in 2012, you had a lower infection rate, and in 2018, it was limited. Any reason for this increase in the infectious morbidity? Like, I also see some reasons, but I would like to hear from you that why this increased figure was there.
Madam, actually...
What to you, Zara? But you, please unmute, Zara.
Ma'am, I am unmuted.
Unmute.
Can you hear me?
Yeah, we can hear you.
No, so we can't hear you.
We can hear you, Zara.
Right,
The
Zara?
data that the 2012 data showed a infection rate of roughly 10%. Now, there is not much change if you look at the new data. The only difference that I showed, the 2020 data, was the difference in UTI infection, madam. But otherwise, the infection rates are still similar, but there might be a slight difference. See, this difference, madam, is not significant. One year it is 10%, the other year it is 12%. That difference is not significant. But definitely now that we have a higher load of patients, sometimes there are 2 patients on one bed. So that kind of bed sharing leads to a slightly increased risk of infection. I feel the other reason is when we were talking about creating awareness in staff, I have often noted that once the staff wears gloves, they feel that they are very protected and they are touching all kinds of surfaces, unclean surfaces, and then they follow it up. They touch a clean surface, they touch the patient. That is also very, very important that we emphasize that gloves are single use. They have to discard those gloves after a single procedure, whether they use it for cleaning or whatever. That also leads to a slightly increased rate of infection in the ward or in the labor room, because they are touching unclean surfaces and then they are touching the patient and then they are also touching clean.
Okay, Zara, actually my second question to you is going to address this issue, that what are the challenges in implementing antimicrobial stewardship program in obstetric surgery, especially in complicated one?
In
complicated one. And the other thing you are going to tell us is the problem faced in training paramedical staff in infection prevention control practice.
Ma'am, we have taken a lot of initiative in training staff. There have been workshops conducted in lots of aspects, like biomedical waste management was one such thing which we took repeatedly, and the entire hospital staff was trained. Now, one aspect is training. The other aspect is reinforcing and reensuring that they practice the right guidelines. For that, we have to adopt some policy. Often when we are on our rounds, check whether what they have learned, they are practicing or not. So you have to take, after you have trained them, we have to go in the ward, we have to see for ourselves whether they are practicing what they have been taught, and we have to reinforce those practices. So we definitely train, but reinforcement part, I think, is a challenge, because that has to be done on a regular basis, and that can be followed up with some encouragement, also some penalization if possible, though also very difficult to do. But follow-up of that training is very, very important. Similarly, for instance, we all know that single-dose antibiotics are effective. But still, I think it is very challenging to convince residents. They are so pro-antibiotic.
Yes.
It is very difficult to convince them in spite of all the data. So I think we need to keep talking about it at regular intervals so that we reinforce this concept and we make sure that they understand, and they also understand that for them, perhaps 20 years down the line, they will have very limited antibiotics, because earlier when we were getting the culture reports, they were at least sensitive to colistin. Now they are not sensitive to even colistin. So they are resistant to all antimicrobial agents. So indiscriminate use, I have seen often residents prescribing linezolid so indiscriminately. So that is why I talked about having a list of antibiotics which only can be prescribed after a consultant approves that antibiotic. Because often residents are prescribing higher end antibiotics even if the organism comes out to be susceptible to the lower end antibiotics or short acting antibiotics. So I think we need to really have that list. I think that list might work for us.
Yeah. Thank you, Zara, for elaborating that. We have Dr. Sujata Baveja.
Yes, ma'am. Good morning.
It's a pleasure to have you with us today, and we would like to share you many of your experience, because you have tremendous experience, and your talk was really wonderful, from basic of disinfectant to a higher level you have gone, and that presentation was really very good. My first query to you is that how common are the outbreak due to viral agent in NICU setting in India? What is your experience?
Ma'am, if you talk about, let me be honest, there are many of us who are not recording these outbreaks because of viral reagent. The reason being, many of the tertiary care hospitals don't even have the facilities for that.
Yes.
It is, we are stuck only with the basic, that is the bacterial and the basic, facilities which are there. And
Yeah.
like from a place where I come from, though it has the first, Asia's first milk bank and many firsts to it, but you won't believe it. At times there are situations when there are three bachus on one bed. So, I mean, there are not many a times we are identifying. But yes, bacterial outbreaks we are having. But the viral, we are not documenting it. And there is another thing, even if we are having it, there is no documentation.
Okay. And what do you say about the COVID wave 3, which is said to be going to affect children? So what do you have to say about that?
Ma'am, our neonates, in the beginning when the COVID thing came, my neonatologist started sending me samples and they were coming to be positive. I'm not denying that. But they were all healthy. There was nothing wrong with them. And, after the Government of India guidelines came that you have to, all pregnant women also have to be screened. We were doing that. We could pick up many COVID people, but the newborns, no, never. I mean, at least in my setup, never, which we had. But the young children now are coming. Not too many again. They're young children who are coming straight with the respiratory distress and this thing. And we are having a separate ICU. But if you ask me, the number is still not much. I hope and believe what we are talking, that it does not affect children. It continues. Because even when we did the sero surveillance for the kids in Mumbai, 50% were positive. Our sero surveillance report for the kids also showed 50% antibody in these children. Compared to what we have, probably they have been infected, or because they don't have so many receptors, the disease is very mild, so they're getting all right otherwise. I'm having, the morbidity is very less in these children, very less.
So what is the future of COVID in India? Because every time waves comes and lockdown and like all the work suffers and the routine patients, OPD gets closed, like restricted number and closure of OPD and all. So what do you have to say about future of COVID in India?
Ma'am, I feel we will have to live with COVID once. We will have to live, but the intensity will definitely go down. And it's more and more people which have to get vaccinated, because now there is enough evidence which shows that if you are vaccinated, your disease is either going to be mild, or the number of the people who are going to get infected is going to be less. And we can never get away without the COVID appropriate behavior. We have to continue doing that. I think, the time has come for us. Like I see we are in Mumbai, and every time we bore the brunt, the first cases also came here and the second wave also started with us. And I had been, actively working for COVID. So ma'am, it is the people also who are responsible. One, they have to have a COVID appropriate behavior. They have to get vaccinated. And the way now we are doing our 5th sero surveillance data. Like when we started the first one, we had only 7% antibody positivity. The subsequent was 17%, and the subsequent was 40 or 50%. Now the 5th sero surveillance is being done in Mumbai. I'm carrying out that sero surveillance. So we will know, and we already know the reports from Delhi, but sero surveillance, presence of antibodies does not give you that you cannot get reinfected. There are enough and more documented cases in which there has been reinfection. The only answer is vaccine and COVID appropriate behavior. And I think it will become like influenza.
Okay.
Am I audible?
There are different vaccines. What do you have to say? Yeah, you are audible. Am I audible?
Yes, madam. Yes, madam.
Am I
Ma'am,
audible?
if you ask me,
Actually,
yes, if you ask me, I still feel Covaxin is the best, which is available right now in
correct.
India. The reasons are it is an attenuated vaccine. It is a virus which has been attenuated. So all components are there in that vaccine. But as far as Covishield is concerned, it is only the spike protein. Though we know spike protein is immunogenic, it is the one which the antibodies against that are protective. But and you know, I do not know the politics or whatever. They have still not recognized, and now there are studies which say that also the Covishield is going to give you lifelong immunity. Covaxin is, madam, we were the part of the trial for Covaxin, and we were really very happy. I mean, it's good results with Covaxin.
Okay.
And I think
So,
it is the safest vaccine. You know, we are talking,
right.
you know, the immune mechanism may get deranged or something. It's the safest vaccine. It's a traditional vaccine, attenuated virus you're giving, and it's working as an immunogen.
Okay, true. So how about third dose? Like how long is actually COVID is new. Everything is, we are predicting and talking about in that term. But how about having a third dose if somebody has received 2 doses 6 months back? Should they go for a third dose of same vaccine or a third dose of a different vaccine? Like I have heard that those who have received Pfizer, now they are going for Covishield after 6 months for more immunity. So what do you have to say about that?
Ma'am, the Pfizer has yesterday only come out with a statement that they have to give booster to these people. They will talk about, you see, the companies will speak about their vaccine, but there are simultaneous studies which are going on, because this has to be a scientific data in which we say, okay, I have taken one vaccine and shall I take the booster by the other? There are some here and there small studies which are there, but madam, still we are not very clear. But definitely a booster, we have to keep in mind. We need to consider that. Yes, madam.
Okay. One more question from you, Dr. Sujata. How common are no. The question is, what is the recommendation of MRSA and ESBL screening of healthcare staff posted in neonatal unit?
Ma'am,
How about their screening?
is through contact, so there is no need. There is no need to screen at all. No need. About MRSA and most of the outbreaks, if you see in NICU, are because of gram-negative. The staph is a dry contamination, correct? If you ask me, there has not been many benefits of this. As far as the screening of the staff is concerned, there had not been many benefits. Not benefits. Because I said again, I'm coming. ESBL is a gram-negative, it is through the contact. So you need to have your good infection control practices. And staph is, you know, a dry contamination. It may be there on your bed railing, on your beds and your pillows. But if you're having good housekeeping practices and you're following infection control practices, it does not help.
Okay. So thank you very much, Dr. Sujata, for elaborating all the questions so well, and we are everyone will be benefited by your tremendous knowledge. Coming to you, Dr. Tamkeen, you have nicely highlighted all about COVID-19 in obstetrics unit. I would like you to share your experience when the COVID second wave came here, because we lost some mother due to COVID. So I would like you to share your experience of mothers getting COVID and their morbidity and mortality. Yes. No, unmute. Please unmute. Unmute. Yeah, that's
I think I would like to begin with the first phase first. Ma'am, on 4th March, the lockdown was there in the whole, Aligarh, in our part of the country. And on 25th May, I received, a WhatsApp message from a patient and many calls from her husband who were just desperate. The lady was pregnant. She had come to the labor room on the triage and she had tested positive. She went away to her own home. And then there was, she was at that time, if you remember, people were forcefully being taken away. There was so much fear of the unknown, both in the healthcare worker as well as in the patients. We ourselves did not know how to handle the situation. And I remember 5 calls from the patient's husband. The whole family was, shifted to one outer some school where they were kept without any food, and the woman was taken to one health facility which was again not well equipped. She sent me a message that there is no light, I cannot charge my mobile, this is just going to be switched off, and there is no fan, and she was desperate. And then compared to that, the second, and we had to arrange, I had to make a call right to the district magistrate in order that food should be there with the patient and for her family. But compared to that, in the second phase, I remember patients sending me prescriptions that, look here, I have taken this, do you think anything else is required?
Yeah, self-medication.
Get bugged up sometimes because it is so difficult to judge somebody, assess somebody's clinical condition or just on a WhatsApp message. But that is a difference that was there, just because people were now not so afraid and they knew what to do and how to handle it. And I think that made a lot of difference for our obstetric patients, also for our part of the world. I think the best thing that we did was that we did not stop providing antenatal care to our patients. So though no OPDs were there on paper, but we continued our own department, and each and every member of our staff, they worked really hard so that proper antenatal care may be provided to them. But still, I remember, in spite of all our efforts, people from remote areas, women coming, just giving us half an hour to be intubated and going for the direct for the death certificate. And I have a collection of about 30 such x-rays where the whole lung is white and the patient is hardly giving me, and she's presenting just like an eclampsia with pulmonary edema. So that is the difference. We did our best. We tried to provide them antenatal care, but in spite of that, those who were in nearby and they were friendly with the facility, they had already come to the facility early, so they knew what to expect, and they knew that we were approachable, that we were providing them respectful maternity care. I think not much harm happened to those women. But the others who are, our catchment area is so vast, they really did suffer, and a lot of intrauterine deaths, a lot of maternal deaths occurred because of and we were not able to provide RMNCH services to these women during COVID times.
Yeah. In first wave, we hardly saw any maternal mortality, but in second wave, we saw many mortality, neonatal, intrauterine death and maternal mortality was also very high. And you highlighted the point, and thank you very much for highlighting that point, that only for obstetrical indication you have to terminate. But in second phase, many a times we got the call where we were asked to terminate the pregnancy just because the patient required a ventilatory support at 28 weeks of gestation and they were asking for. And we lost even VIP patient in this where cesarean section was done and we could not save those patients. So I think that we should learn a lesson. If third wave arrives and unnecessarily we are asked to terminate, we should not terminate, and we should tell them that only for obstetrical indication, unless there are difficulty in mechanical ventilation, that we are asked to terminate this pregnancy. So I think we have covered most of it, but if someone else has some question, they can discuss, or I would like you all to share your experience. Zehra, are you there?
Ma'am, just one regarding my experience of telemedicine,
Please,
I would like to share. I think
Yes.
we were the first department to start telemedicine
Yes.
in the medical college, and we were so enthusiastic about it. And I think we did help a lot of patients by having
Yeah.
that helpline. It was basically a telephone based telemedicine that we were doing, and we were many a times we were able to tell patients that, guide them properly whether they really required admission or not, or whether they should immediately go to the facility. But later on, I saw that patients were making taking undue advantage of this facility that we provided them. 24/7, you advise them one investigation, they send back 74 pages report.
Yes.
Getting
Yes.
it done, and then it is your job to go through those investigations.
Picture in all directions.
One picture in all
One
directions, you get a
all
diplopia just by
Yes.
twisting your mobile phone.
Yes, very
And
true.
then you have those kind of patients where the conversation will never end. They
Yes.
don't know where to draw a line, and they have nothing about a doctor's personal space, because they are not trained that way. Then there are those patients who are not even educated enough to type a message, and then there are those who are making you a desperate call, and when you call back, because you are attending to so many patients at the same time, so when you call back, they say, "Arey, wo to chala gaya, that patient is in another city." So I was just trying, and then sending back the photograph of the medicines, the the font size that is there on the medicines in India, which is against all international laws. And then you are supposed to read up from that photograph of the medicine whether it is the right medicine or not. So all those difficulties we face. And in the about 2 months back, I thought I was really fed up with this telemedicine thing. But still we continued, because I thought sometimes we were able to save a few lives or a few babies.
Some are getting benefit, and of course, we are educated, but the patients are not that educated.
What I wanted to emphasize here, that this opportunity should not be lost to develop, telemedicine, because this way, even in normal times, we can reduce the overcrowding and our own workload. So something should be done about it. Lessons should to be learned, and then do it in a big way, and train the women as well, because for an antenatal woman, it's very easy. They are coming to us for 9 to 11 times during a pregnancy. So if we can decrease those amount of visits, it is going to help a lot in providing proper obstetric care and not overloading the doctors.
It will take some time, but we can plan and we can develop this, because this will reduce the load onto the OPD. Dr. Sujata.
Ma'am, I just wanted to highlight that if we are trying to develop telemedicine, we should only be talking to the patient, because often it is the husband who is talking, or the mother-in-law or some other relative. So we should ensure that only whenever we connect with the patient. And of course, not to forget the kind of messages, Eid greetings and videos that they're constantly sending on that number. So that should also be discouraged, because I think we should constantly be putting messages discouraging this kind of social messages on that particular WhatsApp number, which we were using for telemedicine.
Sometimes it is so difficult to understand their language, what they are wanting to say. And it takes so long to understand that they are talking about fertility problems. So like, koi ghar mein, they will talk anything to convey their message, and it's up to us to take that message in the right direction and then further talk to them or write to them. Dr. Sujata, I would request you to share your experience, please.
Madam, about the same, I'll tell you. In fact, we had one of the MCGM hospital as a COVID identified hospital. So one fine day, you won't believe it, but people from a very affluent family, the lady in the house got pregnant and detected as COVID positive. They just left her outside the hospital, and there was nobody. In fact, that kind of a feeling from people also was there. If somebody has got a COVID, the family was also not there to support. And this has happened with us in Mumbai, And of course, the administration took care of it. The MCGM took care of it.
And when she became all right, and then they sent her. This was in the beginning of the pandemic. Just because she was detected positive, she was left as totally abandoned outside the hospital.
Yeah. Yeah, that is really sad. And when they die, nobody was there to take the body. And these things really happened. The body was dragged without any dignity. They were dragged and disposed of. So those sad things really happened.
Nobody, madam.
It should not happen with third wave should not come at all. And if it comes, this should never happen again, because
but madam, there were no support system. You won't believe it. From the peripheral hospital, or the jumbo facilities which we have, where the mild patients who are being put, the moment they become a little bad, they come to tertiary care hospitals. But there was no follow-up. We tried to contact them on the numbers. There was nobody there. For how long to keep them also? People were not there. They were just abandoned also.
Yeah. So that was sad part of COVID. I hope with time, everyone will improve also in their behavior.
And now people have become so fearless that they don't want to use COVID, they don't want to wear a mask. They don't want to have any COVID appropriate behavior.
Now you have brought a very important point for discussion. How about using mask and what type of mask, and whether this cotton cloth mask going to help us or not? Just tell us something about that.
Ma'am, yes, the one is that if two people wear mask, both the wearer and the person other side they wear, you are protected 80%.
Yeah.
And if you wear the person who's infected, or one of them also wears double masks. I'm talking of double simple mask. The protection increases to 80 to 90%.
Okay.
So it is helpful.
Dr. Sujata, what do you mean by simple mask? That cotton stitch?
No. I'm talking of the triple layer mask. I'm talking of the triple layer mask, madam.
Okay.
Now, even the other masks which are homemade, I'll tell you the advantage of the double mask is, suppose you put one mask, you put one mask and on top of it, you put the other mask. What happens just with a simple mask? See, there is a space, you can see the place. But if you top it up with the second mask, what happens? It tightens it well. The mask which is below gets tightened. And so there is, no outs. You can't, the transmission is reduced. Also, madam, the mask with the highest efficacy, many people we see, it is N95 mask, they wear over a triple layer mask. No, they have to wear the mask with the highest efficacy, that is N95. On top of it, if they wear a triple layer mask, what happens? The chances of getting contamination of the N95 is reduced dramatically, and the efficacy you can use it for longer time. That advantage also you have. But in case you are not in a very high risk settings, double layer mask also is very good, because you can't be wearing N95 mask all the time. That's so at least in our my lab, except where there's a COVID work going on, we wear N95 mask as well as a simple mask over it. But otherwise, we do with double mask because it increases protection.
One practical problem which arises while wearing the mask is fogging on the specs. So how to avoid that? Yeah, because that's a very common problem.
It is a problem, no doubt. You have to press it well. If you press it well and it comes like this, the fogging will be less.
But
if it is covering properly, it will be really less. Because I'm also using specs and I also have a problem. But if you press it well and it is below this, the fogging will be less. And another thing, madam, it's very important. You should not be continuously wearing these triple layer masks for long. Because they also get contaminated. Yes, we do say in resource limited settings and otherwise also N95 can be having an extended use, but the simple mask has to be changed every shift. even patients, what is happening is, in COVID wards, we are giving to these patients these masks, and we are giving them for 2 days, 3 days. No, it has to be changed at least twice a day, because they get colonized and then they can transmission is enhanced.
Thank you very much, Dr. Sujata. With that, our session is also going to come to an end.
Nice.
Thank you all the
Thank you
panelists,
so much.
Dr. Sujata, Dr. Zehra, Dr. Tamkeen, for giving excellent talk, and that is really going to help all the participants of this conference. Thank you very much.
Thank you so much.
Meet
Thank
again.
you.
Thank you, madam. Thank you so much.
Thank you very much.
Thanks.
Thank you.
Okay. Okay. Okay.
Thank you all for such an informative and lucid discussion. I request all the delegates to join us in Hall A for the keynote sessions after a short 10 minutes break. Thank you.
Thank you. Thank you.
गलत हॉल में हूँ क्या?
Yes, ma'am. Please, हॉल ये वाले लिंक पे ज्वाइन कीजिए आप.